Good morning, George, and welcome from Italy.
Yeah. Good morning, Dr. Bravissimo and Dr. Fox. I couldn't miss this episode with Dr. Fox, so I found the time to jump on the computer.
Appreciate it.
It's been a day.
We have a phenomenal guest today, Dr. Shannon Fox Levine, who is a pediatrician. She lived near my parents' house in Maryland, the daughter of a Navy pilot. She's a business owner, leader in her practice, president of her practice, leader in the chapter of Florida Pediatrics AAP, and also a leader at the national level with the Pair Relations Committee with the AAP in Chicago. In her spare time, other than being with her kids and her husband, she also leads a mental health project in Florida. It's a pleasure to have you and welcome to the show.
Thank you. Thank you. Yeah, I follow the Pediatric Lounge on LinkedIn. So I feel very privileged because I know the others who I am in the company with who have been on your podcast. So it's a pleasure.
Thank you. Likewise. So, we always start out by asking you, why did you become a pediatrician?
I actually have kind of an interesting answer to that too, because I think my path was very different than most. And to share that with my patients also, especially now I've been in practice here for 21 years. So I've raised a generation from birth to 21. And I see the stress in high school of so many kids who are trying to figure out, even my own kids, what are they supposed to be when they grow up? I am a great example. It's hard to know when you're in high school. And it's hard to even know when you're in college because I actually went to college, the University of Maryland, College Park, as a criminology major. My idea was to be an FBI agent. That's what I was going to do. I would have said you are crazy if you ever said I was going to go into medicine or anything to do with blood and guts and hospitals because that terrified me at that point in my life. And it was only through going to college and really having an open mind, which is what I encourage my patients to do, just take different classes and see what I liked and realize also like who I started to identify with as friends and realize that wow, everyone I seem to be hanging out with is pre-med and I keep taking all these science classes and I really do like science and let me go to medical school. And so it was
Oh,
actually my junior year of college that I became officially pre-med. And I was a biology major by that point after changing my major many times and went to medical school at University of Maryland, Baltimore, which I have great memories of, fabulous, amazing education that I got, great experience. And with that experience in my third year of medical school, I'm a lover of school. I could be a student forever. I just love education. I love learning things. And I loved medical school just as much as I loved college. So every clinical rotation I did, I was worried because I kept thinking, I love everything. How am I ever going to decide what I want to do? Pediatrics was my last clinical rotation, my third year. And it was the big aha moment that I realized that everything that I loved about all of the subspecialties that I was doing pediatrics really fit that need that what I was loving about them, even psychiatry. Here I am doing a lot of mental health as a pediatrician. So I think that it's so important for our youth to really have more of an open mind and not feel like they're so pigeonholed into picking something to do from such an early age. And it's what has brought me success. And again, I love school. I love learning. And that's how I've wound up being a pediatrician and really how I've tried to now, as a pediatrician, counsel some of my patients through the years. And I have some of them come to me now and say, you did tell me that I should keep an open mind because I did change my major. And I'm like, so there you go. You're following in my footsteps.
terrific. And why would you go to NYU
That's
Langone
always a good thing.
Oh, it
when you
was
were in Maryland?
yeah, but it was the best. Now that was the best experience. That was the best experience. I am a Bellevue resident through and through. If you know us, Bellevue residents, shout out to all of my Bellevue resident friends out there. We are born leaders, first of all. And that is because you have to be as a Bellevue resident. It's on you. Like, here's your patient, figure out what to do. We ran the ICUs as residents. So I got the most amazing experience. My best friends in my whole life are all from residency because we were picked to be there together as the residency directors. They looked for a certain personality type that was going to come in and take over Bellevue. And that's what we did. And we took it over, we conquered it. And I stayed as a chief resident. Again, loved it. Probably
Wow.
would have stayed there if it weren't for the fact for the weather. So I'm not a snow kind of person. I love the palm trees and the sun. And so that's what brought me to Florida after residency.
Wow. And then you're now in Palm Beach and you're an owner and you're also the president of a large, pretty well integrated practice. What does your practice look like in Palm Beach?
So we are a 40-year-old practice. My practice was started by my partner who retired now 10 years ago. And his interest, he had a master's in public health from Johns Hopkins, actually, with an interest in development and mental health 40 years ago. So he was like very much way before his time in pediatrics. And he built a practice that was based on comprehensive care even 40 years ago. So we really have that reputation. And he hired me because of my interest in mental health from residency, from being at Bellevue, it's like in my blood that he picked the providers that he hired that would be interested and be willing to learn from him to continue to manage not only the behavioral mental health component like ADHD, but also autism. We have a really good reputation in our community, in our county, that schools even will refer their children with autism to us to help navigate their care. And same thing for mental health. So we actually have a psychologist who does psychological testing and also some therapy. And we have a psychiatric nurse practitioner as a physician extender for us to help me in particular, and one other pediatrician who see the bulk of our mental health patients to be able to take care of as many of our patients as we can. Our practice, because of the reputation, has 40% of our 20,000 patients have some mental health diagnosis.
Oh,
So
wow.
so we do a lot. And for that reason, we have tried many tactics in the past. I've been very determined to figure out the best model to manage all of these kids. And through many trials and tribulations, actually, we've hired licensed mental health counselors to do therapy for us. But there's issues with that, with trying to get them credentialed under our medical license in our facility. And we need to be able to pay them as much as we'd love to just give free care in a private practice. We can't do that. And so they just weren't really making enough money for us to be able to sustain that program. And so what we realized about 2 years ago with the pandemic and the mental health crisis, really, it was already an epidemic, but this was like out of control with the pandemic. Learned that integrating with a local nonprofit organization who I've worked with closely for now 10 years, the CEO, that has been our best case model. And that's what we continue today to now work on and grow, where the nonprofit organization is able to see all of our patients under their funding through grant money and through Medicaid. They're able to see our patients. And we can refer them internally through our electronic medical records so that they can contact the patient same day to plug them into then a tiered care coordinated system where they realized after the first 2 months that we had this partnership, we sent them 500 patients.
Wow.
So after 2 months of having, after the first months it was 200, and then by month two, it was like 500. Then they realized there was no way that their one therapist who could see 28 patient panels was going to be able to manage this many patients. And so they've developed strategies in working with us on how to coordinate and triage a lot of that. And our practice model is based on care coordination. It's what we actually won an award last year from the Primary Care Collaborative nationally in Washington, D.C., because of the care coordinated model that we have had now for many years. We've been obviously doing mental health long before the AAP was really developing guidelines for all of the different mental health diagnoses. And we knew that we needed staff to help us. We know there's a lot of phone calls that our mental health patients are going to have questions about things, issues with medication, issues with referrals to therapists. And so it began with having our care coordinators who had been from the old days of everyone having an HMO, they were our referral people. So they're not nurses. They're technically referral front desk people. They're now paired up with each provider. So I have my own care coordinator who then is the care coordinator for all my mental health patients, in addition to all of my chronic care kids that just need that extra hand holding to help them navigate this very complex system that we have that can be challenging even for me as a patient to figure out.
Yes.
Our own care coordinators, that model is really what I would love to be able to share with other practices on how they can implement the same concept because it's really so important for that patient centered medical home approach.
Yeah. And so how
Right.
many
You know what's
pediatric
interesting to me? Hold on one. What's interesting to me, what you described, the integrated system with mental health and general pediatrics and so on, is not rocket science. And it works. I think it's proven. Yet none of the cares, nobody wants to cover it. It just makes no sense because it is a problem when the grant money runs out, so does the program. The same thing when the grant with some hospitals and stuff embedded in social work, salt canned off, immediate appointment. One way they couldn't do the billing and they shut it down. Why? It didn't work. Any thoughts on that?
Yeah. And let me just how many pediatric clinicians do you have, either pediatricians or nurse practitioners or physician assistants in your group now?
So we have 3 offices in central Palm Beach County and 1 administrative office, which is a separate location. And we have 5 nurse practitioners and 7 pediatricians, 6 or 7 pediatricians. I lose track sometimes. We've had unfortunately, like, I think a lot of practices locally have had issues retaining staff, and we've had a recent turnover, and we have more people we're hiring, which is good news. So I can also talk to people about that, how to hire new pediatricians. And so then we have our psychiatric nurse practitioner and we have our psychologist. So 15 providers in total.
And how many care coordinators? Do you get your own or do 2 or 3 doctors share one care coordinator?
So my care coordinator, because of the volume of patients that I see that have a need for a care coordinator, I have a care coordinator who has been with me now for many years, probably 15 years, who has one other provider. And then we have care coordinators. We have 5 care coordinators. So then we have care coordinators who may have 3 providers because their providers don't see as much of the mental health. We have other programs that we have for chronic care patients. So asthma, we have an asthma chronic care program that we also need the care coordinators to manage those patients. And we have a new nutrition program for our kids over 12 years old who qualify for medical management of obesity. And we call it nutrition to give it more of a healthy name versus obesity clinic. And those care coordinators also are responsible for those patients. And their role in the practice is really to be that direct contact for any of the issues that may arise in between office visits so that as the doctor who's taking care of the patient, I don't really need to talk to the patients. They talk to my care coordinator, who then we have a daily morning review of patients that have any type of questions or issues and what to do with them. And then my care coordinator will follow up with them with the plan. She also will take messages about for the mental health kids who need a refill of medication or a change in dose in medication. She'll manage that for me as well. So I don't have a lot of that administrative time that I need to manage these patients because it's a lot, but it's a lot of extra time, as all of us pediatricians know.
And what chart are you using now?
We have Athena, which, yes, I know it's can be costly. However, it is very robust in helping us with these type of programs and helping us do really using it to its greatest potential of limiting the amount of time that we need to spend with our documentation, first of all, as a provider, and also for care management. They have a pretty robust care management section to manage these chronic care kids that we're just really working more with now. We also are always learning all the time, and Athena is constantly updating their different types of software approaches to things. In addition, they have partners that they work with, and we're always looking for better ways to use technology. And that's really the key is let's use technology to its fullest to lessen the burden on providers and staff and to ultimately in time hopefully decrease some of the burnout that otherwise can be caused. And yes, I know EMR can cause burnout too, but that's why it's important. This is our third EMR. So it's important, I think, to find the EMR that for your practice is the best fit. And that's where we are at this point with Athena.
And do you use any kind of scribes, either an AI scribe or virtual scribe?
We have looked at the AI scribes. Our concern with that is that we feel like it would probably be more work for us to go through and clean up what the scribe is putting in the charts. We don't have scribes in the office as real humans. We have templates though in our EMR that we have like the behavioral health template that we use that there's a lot less typing and clicking that we have to do. So it's, I think, more of that typical old fashioned approach versus having some of this latest technology. I don't think we're quite ready for the technology yet. Again, just most of our providers by how we practice. And I know me personally. So, me personally, when I'm in a room with a child who has anxiety, I spend the time talking to the family, looking them in the eye, having conversation with them, but remembering everything we're talking about, walking out and putting just the key things that I think are important for me to remember for the next time I see that child, the key symptoms they're struggling with, some of the approaches that have been working, what hasn't been working, and then what our goals are. And if an AI software recorded that visit, it would be a lot more that we're chatting back and forth. I've seen these people for 21 years. So a lot of times what I'm talking about is not something that necessarily needs to be in the chart when I'm checking in on their other family members and finding out what they did for the summer. And so that's been our issue so far with AI. And unless there's something out there that can clean it up better for us that I just don't know about yet, that would be something for us in the future that we would be looking for.
Go
I
ahead, George.
there's yeah, I scribed. I used to think this was weird. You can do meds, what meds do you want? You just do a story and it's an entire story. And if you talk about Jennifer Cancer title and concert that they went to, there was no in it because no, it copied it right into the card. And then the note is immediately deleted off of the scribe portal. Doesn't exist.
Yeah, and that's good. No,
No,
yeah, that's what we're looking for. We're waiting to find that best fit for the way many of us practice.
As the president and managing partner, what KPIs do you keep your eyes on to make sure that the practice is going in the right place?
That's a great question. As a physician who went to medical school and didn't really learn the business end, I figured out the business end as I've gone through the last 20 years of being here. But I still will say that I think the most important KPI to really focus on for me is that patient experience type of KPI, how long they are waiting on hold on the phone to get somebody to answer their questions or make an appointment, how long it is for them to make that child appointment with their favorite provider. Are they able to make that child appointment with their favorite provider? How long are they in the office before the provider sees them? And with the pandemic, we prior to the pandemic, we all had the waiting rooms with the kids coughing and coughing. And we were just like, oh, yeah, that's waiting room. That's what happens in waiting rooms. Now that's unacceptable, right? So we now call our waiting room staging rooms. The staging room is for the patient to come in, immediately be checked in and put in a room that's available. We no longer, as a practice, say that these are Dr. Fox's rooms, these are whoever else's rooms. This is if there's a patient ready to come back and there's a room available, that's where the patient goes. So we've changed some strategies with making sure that patient experience is going to be such that will keep our reputation where it is. And from patient satisfaction surveys, that's where we get our best ideas. Our patients really see when they come in what may make us even better. And so we're always trying to be better. We listen to our patients. And that's why patients refer their friends to us. So 70% of our patients are by word of mouth. That's how they find
Wow.
us. Not from their insurance plan, not from all the fancy social media that we try to do too. And we pay money for all that. It's still, my neighbor said to come to you. My teacher said to come to you. That's where we get our patients from. I never thought going into medicine, I would be saying customer service is really important, but it is for
Yes.
any practice, for any hospital system. I know as a patient myself, I'm mortified sometimes as a patient thinking, oh my gosh, does the owner know how this is working here in this office?
Yeah. Yeah.
And I
And
think it's so important that we don't lose that sight that we are a patient centered medical home.
right.
We-
Yes.
The patient is the center. So, what can we do to make that patient experience where they want to keep coming back and they want to send their friends? And most importantly, they're going to feel comfortable and trust us. And how do we build that relationship? You can't do that if you tell them an appointment time and then 3 hours later you see them, right? Like to build that
Yeah.
trust, all of these things are important.
So there's 2 things there I was gonna ask you. Does Athena automate that reporting so you know when people went in the room and how
Yes.
long the patient was there, and you
Yes.
get reports? Yeah, that's very nice.
Yes, we
Uh,
have a throughput in it. We can set it to give us the amount of time that the patient spends checking in. Once they're checked in, between check-in and the buddy, we call our floor staff buddies because it's a mix of medical assistants and nurses. So we've always called them our buddy. So our buddy, that amount of time that they spend with the buddy, the amount of time then that they spend with the provider, and then the amount of time that they spend as they leave once they officially checked out.
and do you I saw one practice, I've only seen it once in a pediatric practice. The ERs already all have it. They have dashboards to see how long each patient's been in there. And if your metric is to see each patient within 15, the clinician sees it as at least says hello to the patient within 15 minutes
Mhm.
of arrival. They'll turn red when they've been waiting more than 15 minutes. Do you have that in your office or
I don't know if Athena, it might be possible, something that is a great idea that we can look into. I think Epic does that, and a lot of the hospital systems have Epic.
yeah.
And we have in each office is we have a team lead who is the supervisor for the office, usually a nurse or a medical assistant, who is keeping an eye on all of the schedules and making sure any patient, first of all, they're standing near the waiting room so they can see if there's anyone waiting to come back, and then making sure no one is getting stuck in the room. And because with Athena, we can send a Athena text to all of the staff in the office. So if the supervisor, the team lead notices that somebody's been in a room longer than maybe they probably planned on it, she'll start shifting patients around. So that's how we approach that. And they're all great. They're all trained to do that, to keep an eye on the schedule. Definitely something like that would actually flash at them so they didn't have to
Yeah,
calculate it themselves. That would be wonderful.
they
And
might
so,
have it, you should ask them. So
yeah, I will.
Congress,
I will. Mhm.
I do mostly locum tenens and almost everybody in Northern Virginia and through the CIN at Children's National now. They're all ECW, and I
Mhm.
just hate it. And the reason I part of the reason I hate it is because when you open a patient's chart, you lose your schedule. So
Mm.
if I'm looking at a patient's chart to try to figure out why they're here, I have no idea who else is waiting to see me.
Mhm.
And until I close that chart out, I can't see the schedule again. And that just doesn't allow me to see if they put another patient back. I got to go see another patient. I'll try to figure this out later. And that is a really bad design about ECW. And to your point, I always joke that everything in life is a relationship. And my other bad joke is not every date turns into a marriage. But if you're 15 minutes late to meet a person that you're going to have dinner with, and that's your first date, that's it. Most
Exactly.
people are like, "No, thank you. I don't care how much of a pediatrician you are, how much girlfriend said that you're a great person, blah, blah, blah. You made me wait for 15 minutes alone in a restaurant. I'm not giving you a second chance." And I think the same
But
thing
the
is with
second
patients.
time, if you like the person, the second time you're willing to wait, right? And that's what our patients will even say. They'll say they don't mind the wait because they know when they get their turn, we're going to spend the time with them also. But you're right, the first impression is
But
critical.
my point is the same thing, right? This is a relationship you're building, and if you're not respectful of their time, then it's I don't know another term for it, but it's a turn off. You're a really good doctor, right? Office is nice, but every time I come in, I wait 45 minutes to see the doctor. That's 45 minutes I could be doing something else in my life.
Right.
And we lose sight of that. And it's a very important thing that you're measuring. Uh,
Yes, I completely agree, which is why to me that is probably the most important thing
that's
out of
really
everything.
important.
We need to be paid what we're billing the insurance companies for, so we need to monitor the collection rate and the number of visits, and but ultimately, if the patients aren't coming to us because we don't give good customer service, and obviously care comes first, but the customer service is very quick to be a second because it's so important to, again, as you said perfectly, that's how you build that relationship and that trust.
Yeah. I'm starting to believe even pediatricians, but most patients don't understand what quality is. Locally in medicine, 85% of the stuff gets better on its own and probably a little better in kids, thank God. And so it's hard to judge quality, but it is not hard to judge courtesy and do people value my time.
Exactly.
That's very easy to judge. And so that's what you're going to think of as quality first and foremost. And you've already been stuck in a room with three kids and it's a small room for 30 minutes and you're told you just have a cold, you need antibiotics. You're already frustrated. It's going to be a much harder sell.
Mhm.
That's a very important measure that you're doing. What do you think are the challenges to the specialty of pediatrics right now that you're seeing at the national level and at the responsible for because you're responsible as the managing partner president, you're responsible for your other clinicians' way of making a living, your patients and your community, because all those people are dependent on you staying open to employ them. So what do you think is our biggest challenge?
I think the biggest challenge right now is honestly a challenge that we've had since I was in medical school and I chose the profession, with us being the lowest paid subspecialty. And I think it's probably more of a challenge now than it was when I chose the profession, thinking, I'm not doing this for the money, right? If I love what I do, the money will come. But I think the costs of school are so exorbitant now that the medical students are truly looking at this and thinking, even if I go into pediatrics, I'm going to do a subspecialty because I'll have to be able to pay back my $500,000 in medical school loans eventually. So something's got to give there. For one, I think pediatricians should be the highest paid for what we do every day. And I say this to the insurance plans that I work with all the time, both practice wide, statewide, nationally. Come and see some patients with me. And I think you'll feel the same that the amount of work that we put into what we do every day really should be paid at a higher rate. And when you have that 11-year-old autistic child who needs a tetanus vaccine, or not even autistic, they're just nervous and they're 11 and they're nervous. That takes so much more work and effort than giving an adult a shot. I think we're undervalued as pediatricians. And I think the root cause of that is Medicaid, that half of the kids in the country have Medicaid, and many states are paying a third of Medicare rates for Medicaid care. And that is something that definitely needs to be fixed. I also think what would help is if medical schools like NYU, and I know some others are on board now, somehow were subsidizing costs for medical care, and maybe to encourage primary care and pediatrics specifically to say, if you go into pediatrics, then we will waive your certain percentage at least of your medical school costs, so that the residents aren't so fixated, or the medical students aren't so fixated on choosing that subspecialty that will be able to help them pay back their loans. The other interesting phenomenon I've seen recently too. Currently, I have a psychiatry resident, an intern who is with me. It's a new program we've started with a local psychiatry residency program to encourage more psychiatry residents to go into child and adolescent psychiatry. So, what better than to hang out with us and get a feel for what it's like to see the kids? And what she opened my eyes to is that she was in school during the pandemic. And so being a medical student these last 4 years was challenging because their clinical rotations were limited. There weren't a lot of sick kids also. Remember those first few years of the
Yeah.
pandemic, and kids weren't even getting it, and that the adults were taking over the pediatric floors. And so the exposure, I think, during these last 4 years for pediatric care has been less, or definitely less than we probably had 25 years ago in medical school. And that's just a recent observation. She's one, but I've heard that from a few other people when we interview them, that they just feel like they didn't quite get the experience because the pandemic. There was always something. And this recent hires of two new pediatricians, just their residency training, they feel like was somehow affected by the pandemic and just not doing the normal type of rotations that you would have. So I think that too, which that hopefully, as we hopefully are getting out of the pandemic, I'm hoping that will get to a point where the students are going to be back in rotations, getting more experience. But the other thing is now we have preventative for RSV. So how many kids are really getting hospitalized anymore? And maybe medical schools need to do more outpatient training and not as much of the inpatient NICU, PICU, all of those rotations. Just some of my
No,
general.
those are great observations and ideas. I think we're in real trouble.
Mm.
And George's son is in medical school, and he wants to follow his dad's footsteps to be a pediatrician.
Yay.
And his girlfriend is delightful. Actually, Emily's such a nice kid. And she said to me, I don't know her. Maybe I'll be a psychiatrist. I can make 350 a year starting out, and I can work from home. And once I have a family, it would be so much easier if I could be home than if I had to be running around in an office with set hours. If something happened that I have to go pick up a kid from school or something, I can just cancel the appointment, reschedule it for later in the day, and go pick up the kid and bring him home, put him in his room, and go back to the Zoom calls. And that's a lot more than any pediatrician does when they start out money wise. And if you think about it from lifestyle and income potential, yeah, that's a no-brainer. How can you argue with that? I don't know that I could do I love psychiatry, but I don't know that I could listen to people and their pain in that way for 8 hours every day. I don't do a good job of putting it in little rooms and walking away from it and forgetting. I think it's a pediatrician thing. I go home and I obsess over the kids I saw, and it's
Yeah.
like, what am I going to do with that obese kid with obesity? Is he's already insulin resistant and hypertensive, and how am I going to tackle that? And I ruminate over
Mhm.
that poor kid, and I think that's just a pediatrician thing. I don't
Mhm.
know, but other doctors go home and worry like that. But I would think that as a psychiatrist, I would worry about these patients, and it would I don't know how to keep it in a compartment. But I can see her point. If you can do it from home and not wrestle kids to look in their ears and not wrestle them down for an autistic kid. I had one kid, this is the funniest thing. I was covering a friend's office, and he must have been 12, 14, big boy, and he needed a COVID test because without the COVID test, they wouldn't let him back into the ABA group therapy. And they was like, "Oh, we're not gonna be able to do it." I'm like, "I'll help you hold him." So I went behind a chair and I put my arms around him. The kid picked up the chair and me and slammed me up against the wall. And the mom was like, I'm like, "This is pediatrics. It's a full contact sports. It's not his fault. Sometimes the kids pee on me. I'm used to that. Sometimes I'm gonna check the hips and I get poop in my hands. I'm used to that. I just wash them. It's just baby poop. Who cares? It's a contact sport." And the other thing I think is so lifestyle is very important. We can't give it to you in pediatrics. Kids get sick when they sick. They want evening hours. They want weekend hours. You have to be on your feet. You have to go from one patient to another. The other thing that's got me very concerned is, and I loved this when I went into pediatrics, it was pediatric infectious disease.
Mhm.
Pediatric infectious disease fits me very well. It's binary. You have an ear infection. Gerald McCline did the studies on it. I know what the pathogens are. I know what the sensitivities are to the antibiotics. I have an algorithm which antibiotic I start with. If they fail in 24 or 48 hours, I see them back. I switch it. Infectious disease is wonderful in that you can culture the bug and figure out exactly what you got to do. And it's quick. And now I think we're moving to chronic disease management.
It definitely is. And just think about the AAP news, right? Like our throwaway news. 10 years ago, even, there were so many more infectious disease
Yeah.
types stories for things like RSV. And now it's all mental health because we, as pediatricians, are doing what we need to with preventative care. And we're keeping our kids healthy and giving COVID vaccine. And so we're not seeing the same amount of illness. Our old like flu season mm, is really not as prominent as it used to be 10
Oh,
years ago when we all dreaded it and we all saw 40 patients in a day.
yeah.
It's extremely rare anymore because we're immunizing the kids for influenza. So it's really, the landscape in my career has changed significantly. And the other thing that has changed, like it mind blowing, is even 10 years ago, we didn't have all these screening tools to ask questions about mental health. And now I have a slide that I do a presentation for the schools to tell them like what the pediatricians are should be doing in the office. And it takes up an entire slide with all of the different screening tools that we administer for our families that didn't even exist
Yes.
when I was in training. I just had learned the Vanderbilt when I came out of training for ADHD. We had the Connors in training. And
Yes.
then it exploded after that. And the interesting thing about psychiatry, when I went to medical school and came out to decide what residency to do, they were the lowest paid. They
Yeah.
were our pediatricians, right?
Because
Because what happened? They don't take insurance anymore. But what happened to access to care? It doesn't exist
yes.
anymore. And
Yes.
so this is the huge mental health crisis, right? This is
Yes. Eh,
we need to
eh,
get the insurance companies to pay these psychiatrists better so they will take insurance because why should my families that are paying a large amount of money from their income every year towards health insurance. Why should they have to pay $800 an hour to see a psychiatrist? It should be by their insurance, but the psychiatrists, luckily, don't take it. So what
No,
do we?
because there's so few of them. They're like, "Okay, this is what I charge." And, there's very few psychiatrists. This was I'm gonna get myself in trouble, but this is the same misinformation as they're doing with mid-level providers. Um, the thing was the psychiatrist will work at the top of his license, and then the social worker will do the talk therapy. And what happened is they didn't pay for either one. And so now you can't get in even if the parents want to spend the $200 a week to see a psychologist, there's very few of them and they got 6 months waiting list. And the psychiatrists have even a longer waiting list. And you're going to pay cash or you're going to do a 10-minute med check.
Yes,
And it's $150 for that 10-minute med check. And that's because we didn't fund the program and we lied to people. And if you don't pay for the services, no one's going to give them.
exactly.
And the problem that I see more and more is that obesity, pre-diabetics, metabolic syndrome, that's becoming a bigger and bigger part of the practice. And it's the same thing as mental health.
Yes.
It takes a lot of time to do the care coordination. And there's no one. I laugh. I know you're a much bigger supporter than the AIP. I'm not a big institution person because I have no patience. But
Yeah.
when I read their obesity guidelines, I had a stroke. Yeah, you're truly gonna find a parent that has the money and the time to take a kid every week for an hour's worth of therapy for 6 months. Truly? Even if you find the program that would accept them, the parent's gonna say, "No way. Oh, okay, I'm just gonna all give them all Ozempic." Great. That's $1,400 a month. Medicaid in Virginia will fight you tooth and nail not to do that, not to pay for that. And
Yes, here too.
a lot of the private payers are like, "We can't afford that. That's $14,000 a year. That's what we pay on the average to take care of a person altogether. That will double our cost." So, thank you for giving me guidelines that I can do nothing with.
Mhm.
And that's where the frustration grows because I have a kid that is sick in front of me, and I have no pathway to actually help. And it takes a lot of time, and then I don't even get reimbursed for it, paid
And
for it.
and again, if insurance plans pay the dietitians, then the dietitians would take insurance, which
And
again,
there would be more, right? But
right,
no.
people would go into it. And the same thing with psychiatry. If the
Yes.
insurance plans paid them for their services, fair wages, they spend an hour with a patient, they should be paid for the hour with the patient. So this seems like it's a pretty simple solution,
Yeah.
but it takes the insurance plans to actually pay the money. And I do feel like it's possible. It will take work. And that's what we all keep working do.
Yeah, but as it trickled down, right? So, we've been in practice long enough that I started practicing before rapid flu tests were ever and
Mhm.
for there was no Tamiflu. It was just the kid had the red eyes and 103 fever, and he looked like the other 10 kids you've seen before, and it's like Motrin, lots of fluids, call me if the kid starts screaming up with his ear, or if he's worse, we'll look at him again. Then we started giving everybody the flu vaccine. Then the pneumococcal vaccine came, and otitis media disappeared. And now we got Beyfortus, which I think is a miracle drug, but it's going to cut down some of the regular colds, which is great for the kids. But we can't do chronic care and get paid like we did for the quick infectious disease that we make it up on volume because you
Right.
cannot do chronic care quickly. It's impossible.
And
Uh,
again, where that education to the payers is really so important because they don't get it. They don't understand what we do. And I think even just me inviting them to come and see what we do, that's enough for them to think, okay, she must be really serious here, that whatever they're doing is pretty special and we need to pay attention to this. because I've never had any of them actually take me up on it. I'm waiting for the day where one of them actually takes me up on coming and seeing exactly what it looks like in our office every day with the patients that we see.
And so, to that point, what is it that the pediatric councils do at the state level
Mhm.
in terms of getting payers to understand that payment needs to be fair for children to have access?
I'm pretty fortunate to be in a state here in Florida that our Florida chapter of the AAP actually sued the state and won for Medicare parity. And I was a part of the actual initial 5-year agreement that had to be rolled out to get the funding for the state to pay pediatricians. And there are certain qualifications initially, and now pretty much you just have to be a patient-centered medical home or meet certain HEDIS criteria to be able to be paid. The incentive pay is essentially what it's called, but it equals Medicare rates. And
Okay.
so the that's where access to care was defined for me. That's where I had that aha moment to say, "Oh, okay. This is how this works, that if the doctors in the community are paid better for the services rendered, they're going to see the patients." And so it not only affected us, we've always had about 30% Medicaid as part of our patient population. But what it really helped us with was to get our patients the subspecialty care that they needed because the subspecialists did not take Medicaid in our area. And so that access to care is through payment for services. It's that simple. It's a simple math equation. And so the state council, and I was the chair at the time of this final agreement and being a part of this eventual rollout. And now I think we're on year eight, I think it was 2016 that they extended it because it worked so well to get better access to our state Medicaid kids. And then working with the mostly Medicaid, that's probably where our state council does its most. The private payers are all tricky, and trying to get meetings with people who can really make decisions about things is challenging. In the end, the payers themselves, they're humans, they're parents oftentimes. So they have kids, they go to the pediatrician's office. A lot of times it's not so much convincing them that it's something that they need to pay for. It's giving them the language to go back to the decision making people in their plan, Florida Blue, for instance, for them to then advocate for us. So it's really this education model to educate the payers, then collaborate with them in order to ultimately advocate for not just the children, but we're advocating for pediatricians to allow us to be paid, some specialists to be paid in order to give that care to the children that need it in the state. And so
Absolutely.
that's in a nutshell what our council mostly focuses on. And again, being part of that agreement that we won 2000, it extended for many years, a lot of hard work that the people at the time in the state chapter dedicated to this. And then I was just fortunate enough to come in at the end when the decision was made and be a part of this now for the last really 10 years because it started about 10 years ago with the whole process. Mhm.
The AAP Florida is a very well organized chapter and tremendous leadership and very effective. So is the Rhode Island chapter. Virginia,
Yes.
the Virginia chapter is also very well organized and not as effective. We're not even at parity with care. And you also are, now that you've done your stint at the state level, you've gone to the national level with the Advocacy and Payer Council Committee, something like that. And
Yes.
what does that committee do, and how does that work?
Yes. The Payer Advocacy Advisory Committee. So it really makes sure that the same thing at the national level, that if there is a plan that is not paying properly for something. Recent case, Bayfortis, making sure that we were educating all the plans as far as what they should be paying pediatricians immediately. Because technically, the plans have a year before they really have to pay for any new code, and that would have been, devastating. We would have missed an entire season that we could have been preventing RSV. And through PAC, we call it PAC, that we were able to educate payers as to why they should pay this, and they understood this, and they have. That's again pediatric council, but then at the national level, and any issues that seem to be pervasive. So not just necessarily Dr. Jones in California who's having an issue with something, even though it does help individual pediatricians as well. If you submit any type of concern onto the AAP coding hotline through the AAP website, then they get filtered through whether it's a coding issue or whether it would be something that would be for PAC to review and decide whether it's something at a national level that should be addressed, or definitely we still help individuals too with just sometimes even locating rep, their local contract rep for Cigna or something. So we can help with that, but it's meant to be more at that national level for major issues. And again, making sure the education is there, that the payers understand why something is important. Symbicort is a recent discussion of why we need to, because of the new smart therapy guidelines, be able to prescribe Symbicort since it specifically states it's Symbicort that we should be using for even rescue now. And so with
Yeah.
rescue, you're going to use more than one inhaler a month. And so to be able to have the quantity that you may need. So that's another example because that is national at the national level with plans that could be just state issues, but still everybody nationally should be on the same page as to why we would need to prescribe more than one Symbicort inhaler for a month.
Yes. And then I put out a couple of codes because I think it's incredibly important as we move from infectious disease to chronic care management. And the G2211, which was really championed by the American Academy of Family Practice. Unfortunately, in New York and Virginia, which I have access to the data, the Medicaid MCOs are not reimbursing anything for that. And for those people that don't know that, the idea was that there is extra work that happens in primary care longitudinal follow up of a patient. And this code was supposed to be an add on to compensate for that extra care that we're providing. And I think it's incumbent upon all of us, industry, and when I do say industries, pharma and pediatricians and medical societies, to make this a very single and most important advocacy point that G2211 needs to be paid by all payers at 200% of Medicare because it's a small spend for them because only primary care physicians are going to use, but it is a huge bump up for the practices to be able to spend the additional time and resources to take care of the child with obesity, the child with prediabetes, the child with anxiety, the child with depression, the autistic child, the child with ADD that's not doing well in school. And that's what it was meant to do. But unfortunately, it has not caught on. And some of the national payers that did roll it out are now bundle. And that doesn't really help us to maintain our workforce. I don't know if you have any thoughts on that one.
And to grow it, because as you said, it pays for the resources that are required. And we've been doing this for a long time, but we are a big practice, really. So we can budget for these staff that we know are critical to the model that we know works best for chronic care management. And other practices that want to be able to do this, smaller practices, they can't afford to have a care coordinator who is working one on one with one of the doctors to help manage all their patients. They might have two staff in the entire office if they're a one or two doc office. So that is really what this is for, is it's for those smaller practices to be able to now look towards what is that next level of care with these patients that are very time consuming, and to give them the best care. You need the support. You need the support. My patients adore my care coordinator, and I'll tell you, she knows things about them I don't even think I know.
Of
She
course.
knows them so well, and she is worth whatever $16 I might get for a G2211 code. How many of those $16 can I give her to continue to do what she's doing for my patients? And,
Yes.
and for me, ultimately, so I can see more in the office. So that is the true physician extender concept now, too, is not just someone who is physically putting a stethoscope on patients, but also who is managing that chronic care. Because guess what? That's going to help the outcomes for adults. And that's our goal as
Right. That's
pediatricians,
gonna
that preventative care to help improve adult outcomes even.
yeah.
So it's so important. The real thing, and again, being at the pediatric council level, understanding kind of how these things work, it's gotta be on the fee schedule. So that's the first
Right.
thing. We're trying to get it in the state of Florida just on the Medicaid fee schedule because, even though we have a big payer currently in Medicaid that is paying us, the others aren't because it's not on the fee schedule. So
Right.
sometimes it's just those things that you have to have people advocating on your behalf, which is the role I play, to figure out, like, how can we, again, educate the pediatricians, say, okay, we're working on it. It's not on the fee schedule yet. Educate the MCO for Medicaid. Can you help us? This needs to be on the fee schedule so that we can go to the managed care plans and say, it's on the fee schedule now. Can you please pay us? The other plan is paying us. So can you? So sometimes it's just the administrative end of things that, and I hate to always sound like I'm giving the insurance companies excuses, but I just think that collaboration is so important. Like we're all in this together. And in the end, it's keeping our kids healthy. That's what's important. So what can we do to help each other get to that end goal?
Yes. And so to that end, the care coordination codes like the 9949, as we talked before, relationships are very important. And we've lost our relationship with our pediatric subspecialist because nobody has time. Nobody's really making money.
Mhm.
And so to put that phone call in place, I feel bad. They're not seeing patients. They're not getting paid. I don't want any free advice, but I also don't have time. And in Virginia, Medicaid's not paying for that. So we have a beautiful Virginia Mental Access Program that Sandy Chung started. But
Mhm.
if I spend an hour on the phone with a child psychiatrist, the people that are paying me to cover their practice are not making any revenue. They can't sustain it. And it's so important, not only for mental health, for diabetes, for obesity, for all these chronic diseases to be able to talk to the subspecialist of, I'm sending this kid because I've done this and that, and they haven't lost any weight and they're hypertensive and I'm concerned. And even that's so important. And oh, can you do this and that before I see them so that when I see them, everything, the workup's complete and I can actually help you. And those conversations are incredibly important and they lead to better care and better outcomes. And not paying for it is foolhardy because you'll pay for it later when the kid has another complication as an adult. And then the one that really gets under my shoe is 96127. As you said, there's so many screening tests that we have to do now: anxiety, suicidal ideation, depression, and the payers expect us to do this work for free, and we're not exactly making $1 million a year. Where am I going to get the money to pay the staff to do it and then discuss it with the parents?
Exactly. And that's another one in the state of Florida. It's not on our Medicaid fee schedule. And it's a work in progress. We have to continue to push and educate, but they're doing it. It just, again, They have their calendar year, and that's when things can change. And it's okay, we'll hang in there. And in the meantime, again, some of the plans do pay us anyway. But that always makes me a little worried too that they're going to come back and say, "Oh, we shouldn't have been paying you for this."
Yeah,
So
they'll
now
take it
we're
back.
taking the money back. Yeah, because that has happened to us before too. With the vision screening years ago, that happened to us. And so that's again what I've learned through experience is that the best way to do this is to really push for Medicaid to add this to their fee schedule or for other private payers to understand why they need to pay it and make sure that it is in their fee schedule for us to be paid something for it. And how much we're paid, as long as we're paid something, at least we're heading in the right direction versus having
Yeah.
them
Yeah.
not pay us anything.
And I was going to ask you something about quality improvement programs because this is a concern. So there are now more interventions that cost money up front, either in labs or other stuff. And there's these medications that are coming on the pipeline. There's a bunch of monoclonal. There's a monoclonal that just got Dr. Woods did a beautiful paper at Hopkins on a monoclonal antibody that if you give it to the kid for 16 weeks, starting at year of age, you decrease the risk of them having problems with peanut allergies and they're already allergic to multiple foods. And you never know when they're going to get accidentally exposed and have anaphylaxis. And how do you carve that out? Because if I'm just unlucky and I get 3 kids with multiple food allergies and bad asthma in a year, I look a lot more expensive than my friend down the road who doesn't have that patient population. Or if I'm screening for T1D and I pick up 2 kids that have the antibodies already and are going to end up being diabetics, will people say, "I don't want that kid because it's gonna mess up my QIP when they start having to need insulin." How is that being addressed at the national level? These things are gonna happen. That's what insurance is for. Why should I be penalized because 'cause I'm doing the work right?
And I definitely agree. And I think with as with everything, it's really about understanding the agreements that you're getting into with payers and with the value-based care. I I really do think we shouldn't shy away from value-based care. It's the future for us. But understanding what that stop loss looks like and are drugs included and are the drugs that the subspecialists prescribe
Yeah,
are
because
you getting dinged for this? Because we do,
yeah,
and
we do.
that's what I've learned, and again, I learned the hard way, I don't know, and then I learn, and then I try to educate others about, "Okay, make sure you watch for this because this happened to me." And so, yeah, our subspecialists locally are prescribing fancy things, and then that dings us in our pharmacy bucket on that value-based care plan. So, we've learned and now working towards the future with that healthcare plan to figure out how to have some better, at least transparency, where we have a sense of where we are being responsible for something that a subspecialist is prescribing. And doesn't mean that we need to educate the subspecialist to some degree too, because they are just prescribing whatever they think is the latest and greatest. And they think, oh, great, yeah, it's covered by this plan. But what does covered really mean? And I think there's a lot of work there that we could do again with the education and collaboration, that whole to advocate for the patient care, which is obviously important. We've done this for years with the ADHD drugs, right? Like we've struggled for years with ADHD medication and getting them covered by the plans, even though they work beautifully for the kid. And so, how do we really continue that to the next level of where it really can be cost savings in the future for healthcare in general? And I always feel like there's many ways to skin a cat usually. So it doesn't mean that we always have to prescribe the most expensive medication, but if that most expensive medication works and is the only one that does, we should be able to, if we're being smart about all the other kids on that same class of medication and we're making sure that they're getting the first tier medication. So there should be wiggle room, and unfortunately, when it's not in our control because it's the subspecialists who are prescribing it, that makes it more tricky. And so again, with those value-based cares, like really looking at that and seeing how the plan is going to take that into account. And again, understanding that this may be a concern if all your kids are on these type of medications from your local subspecialist.
Yeah, but some stuff you can't what are you gonna do? So some of the stuff you can buy reinsurance on the bigger groups that do upside and downside contracting. You
Mhm.
never know you're gonna get a kid with bad leukemia is gonna need a bone marrow transplant. And so they get reinsurance and that gets carved out. But if someone needs a medication that costs $200,000 and they need it, why is that being put into my pharmacy bucket? That's an outlier. So
Exactly.
that conversation has to say, okay, most of the time when you see strep and otitis media, you're doing generic amoxicillin. It's costing us $3.50 there. You're not going, fancy there. But there's going to be outliers. These outliers are going to be taken out of the average of your cost because they're outliers. The outliers can't, when you're prescribing mostly, pediatricians mostly prescribe 5, $10 in prescriptions. All you need is one kid with a $200,000 pharmacy cost, and it'll just totally skew your average. And the conversation should be these outliers need to be taken out because we have no control over them. We're
Right.
going
And
to
it's the
we
same
can,
even with the chronic, those illnesses that are hospitalized, the hospital costs for that same child with leukemia. There should be that, just that stop loss, that it's only to a certain extent are we somehow responsible for that. And then it falls off of our plan. We struggle even with kids who are assigned to us that don't even live in our county by some of these plans. They're on the other side of the state and they're in the NICU for 3 months and they've been assigned to us, and so we get penalized for that.
oh,
And
wow.
that takes communication. So again, frequent communication with our plans that we have these type of plans with to help them understand why this doesn't make sense. We've never seen this kid. We never will see this kid. Please take them off our plan. And they do because they know it's an error in their system, whatever. Blame it on the computer. Computers get blamed for everything. So
The worst one, the clinic I'm helping today is a sole practitioner, mostly Medicaid. And I've heard the office manager argue with one of the MCOs about, you need to take that patient off. I can't immunize him because he's diseased. He passed away. Oh, we haven't gotten that from Virginia Medicaid until Virginia Medicaid tells us that to de-enroll them, we can't take them off of or they have to pick another PCP. How can they pick another PCP? They passed away, and you can't get them off of your attributable lives. So those are the hard things. I've really enjoyed chatting with you. Is there anything else you want to share with the audience before we sign off to be mindful of your time today?
I think that the future of pediatrics, we've just talked about that the future is more of the chronic care management, getting medical students excited about that in medical school so that they want to go into pediatrics and showing them how we can make such a huge impact. Trauma informed care is one of my specialties in the area, and educating my peers, my community about that we are it. We are the boots on the ground. So if we identify the kids who are struggling with the trauma at a young age, as I mentioned before, this affects adult outcomes now. We know that childhood trauma causes not just adult substance use disorder, depression, anxiety, but autoimmune disorders, cancer, COPD, obesity. So we can make such a huge impact by identifying the children that are struggling in a not the most conducive environment to grow up in. And how can we support that? And really, where are all of our kids? They're in school. They're not coming into the office unless they're sick or we drag them in here once a year for a checkup. So, how do we work with schools to make sure that these kids are identified? And the best news of all about that is that the recent literature does show, the data shows that the positive childhood experiences can counter effects of adverse childhood experiences. So, that That's exciting to me. And so getting medical students excited about thinking about that for the future, because then you're talking about multiple types of medical illness that you can prevent by just developing programs to support our kids, and all kids, not just the kids that we can see in our office, but how can we affect all kids? So the future, I think, is more for that. And in our practice, we have some really exciting things coming up in the next, probably take us a few years to get there. So I'd love to catch up maybe in 3 or 4 years and I'll tell you
Oh,
what,
I hope sooner than that. I hope you're back in the podcast sooner than that to talk about
it may take that long to get all of the plans in place. So,
'cause there's a lot of work. It's not I
yes.
say there's 5 things that are preventing us from doing what we wanna do. We don't have any time. We're not
Mhm.
being paid for the work we're doing. We have a workforce shortage. We lack the education, and this is just human nature. I Nobody likes to give bad news or have difficult conversations, especially when you walk in the room and say, "I think your kid failed the chat. I think you may be an autistic kid. And what can I do, doctor?" "Nothing, because no one's seeing autistic kids in Northern Virginia right now, so you gotta and the waiting lists are closed. It may be 18 months before we can get you a clear diagnosis, and without a clear diagnosis, then you can't get ABA therapy, which is what you're supposed to do, and I'm not gonna give you medications until I know that you've maximized the ABA therapy because that's what you're supposed to do." And the parent just looks at you like, "That's not much help."
Mhm.
But then it's not. So we need to re-educate our workforce, and that's gonna be a Herculean task and give them the tools to be successful. That's the heavy lift that we have in our specialty. Make sure we get paid, and we're gonna have to re-educate. Bunch of mini fellowships and get back up and started. But it's exciting because there's new things for us to do,
Exactly.
right?
Exactly. Always learning and always working towards those goals of just best medical care we can give.
Yeah. Thank you so much. Wonderful to see you, and I look forward to seeing you in Orlando soon. I'm
Yes.
really
Yes.
excited for that.
You're in person.
Yes. Yes. Thank you.
Okay. Thanks, Herb. Have a good rest of your day.
Thank you. It's great to see you.